My name is Hermann Einsele. I'm director of the Department of Internal Medicine 2 at the Julius Maximilians University here in Würzburg, and I'm chairing a large multiple myeloma program, but we're also working on different strategies in immunotherapy. We've actually been the first ones worldwide that actually use bispecific antibodies in the clinic. I've also been very heavily involved in the clinical development program of bispecific antibodies in multiple myeloma. We also have a quite extensive CAR T-cell program, but the topic today is bispecific antibodies in multiple myeloma. So bispecific antibodies are really a strategy to redirect T-cells. We have the problem that in any tumor patient, also in myeloma patients, we have very few T-cells that are directed against the tumor and that are functionally active. And so the bispecific antibodies are a strategy to link functionally active T-cells that have a different specificity to a tumor cell, thereby forming an immunological synapse and thereby redirecting T-cells that are, for example, specific for virus-infected target cells to the tumor cell. And so these bispecific antibodies kind of redirect functionally active T cells in the peripheral blood now to go to the tumor and kill the tumor cell. The first format, so different formats of these bispecific antibodies. The first ones that went into the clinic and are already approved in the clinic are the so-called BiTE antibodies, very small antibodies, and they really link the T cells via a CD3 binding domain to a tumor cell via directing a surface antigen on the myeloma cell. And with this, they can actually lyse the tumor cell, but the disadvantage and the advantage is that they can get around the lack of MHC class 1 and class 2 expression, and lack of co-stimulatory activity, which is very typical for tumor cells as well as myeloma cells. Now, these small molecules, they require long-term infusion. So that was an issue when the first trial was done. The first trial that ever was done in multiple myeloma was the so-called AMG 420 trial, in which a BiTE molecule targeting BCMA, which is heavily expressed on myeloma cells and nearly exclusively expressed on myeloma cells, and a second binding domain to CD3. So the T cells were redirected against BCMA on myeloma cells. And what we could see in this trial was that at the maximum tolerated dose, we had 70% overall response rate in heavily pretreated patients with 50% complete remissions and MRD negativity. And we now see patients that are beyond therapy now for more than 1 year and still in continuous remission. So high efficacy. But the drug has also some toxicity. So we saw, because of this long-term infusion, we saw some port infections, some central venous catheter infection. We saw opportunistic infections in these very advanced patients. So they had to receive a median of 3 to 4 lines of therapy, and we saw some cytokine release syndrome, which was still not very extensive, and we saw some immune-mediated polyneuropathy. Now, there are 7 other bispecific antibodies already in clinical development, all targeting BCMA, and the results are quite similar. So high efficacy in the high dose level, some cytokine release syndrome, some infectious complications, but a very effective anti-myeloma therapy in quite advanced patients with sometimes triple or penta-refractory myeloma. And the future strategy is now to move these bispecific antibodies to earlier lines of therapy, to increase their efficacy, to combine probably the targeting. So there are now also bispecific antibodies not targeting only BCMA, but also GPRC5D, which is another interesting target on the myeloma cell. So maybe combination of bispecific antibodies can actually increase the efficacy. And the other strategies is to combine them either with checkpoint blockers, because we know that on myeloma cells, the immune checkpoint molecules can be upregulated and thereby inhibiting the efficacy of bispecific antibodies. And a further strategy nicely developed by the lab of Ken Anderson is the combination of bispecific antibodies with IMiDs, for example, Revlimid or pomalidomide, which seems further increase the efficacy of these bispecific antibodies by maybe downregulating the checkpoint molecules or increasing the efficacy of the T-cells. So a lot of things that are ongoing. I think bispecific antibodies will be an important part of the treatment of patients with multiple myeloma in the future.